All right, and welcome back to Abnormal Child Psychology. This is going to be the last lecture of the year. Congratulations if you've made it this far. With regards to today, both Pan and I will be releasing a video. They're going to be much briefer than the full lectures that we've been doing before. I'm going to try to keep this one close to an hour. It might go a little bit over an hour, but I'm keeping in mind that Pan is also going to be posting her own video about eating disorders. I was supposed to be talking about both autism spectrum disorder as well as childhood onset schizophrenia. However, given that I reviewed all the material and so forth, and given that, I was going to say relative rarity, but just the rarity of childhood onset schizophrenia, I don't think that it's entirely necessary to devote a whole lot of lecture time to it. So I've removed that from the lecture. I do encourage you to still do the readings for childhood onset schizophrenia. It still will be potentially testable during the final exam. However, certainly there's going to be less weight given to that as compared to autism spectrum disorder, eating disorders, mood disorders, things like that. Okay, so I hope that makes sense. If anybody has any questions about that, feel free to shoot me an email, and hopefully I can clarify it for you. Okay. Like I said, today we're going to be talking about autism spectrum disorder. Otherwise, you might hear me call it autism throughout the day. This is a disorder that I'm sure most people have at least a passing familiarity with, given its prominence in, pop culture over the last couple of years. There are many different characters in television shows and so forth that have been depicted as having autism or being on the spectrum, as it's sometimes referred to. At the very least, I can't imagine another mental disorder that's had as much PR in the last decade, at least, maybe the last 2 decades, in terms of doing really good advocacy work on the behalf of people that are living with this disorder, and getting a better picture to the general public of what ASD actually looks like. Now, not all depictions are perfect by any stretch of the imagination, but this is something, like I said, I would imagine most people in the class have some passing familiarity with what ASD is, or autism spectrum disorder. So today I do want to highlight that we're going to be talking about a number of things related to ASD. We're going to be talking about history, in terms of history of the diagnosis. We're going to briefly touch on that, briefly touch on diagnostics. I'll spend a little bit more time on that. Talk about associated features, so things that aren't necessarily diagnostic criteria but are commonly seen in people that are living with ASD or people that are on the spectrum. And we'll talk about prevalence very briefly, socioeconomic status, that's SES, so socioeconomic status, and sex-based differences in autism spectrum disorder. And then we're going to spend a little bit more time on course and outcomes, and certainly some more time on etiology. I didn't put it in here, but we are going to talk briefly about treatment towards the end. Given that this isn't an intervention course necessarily, this is more of a mental disorder course, or abnormal psychology, developmental psychopathology course. We're going to spend most of the time talking about the disorder itself, less time talking about treatment per se. Okay, so moving on. ASD, generally speaking, or autism spectrum disorder, it's a pervasive developmental disorder characterized by 2 broad categories of deficits. We're talking about significant and pervasive deficits in social interactions and communication with others, and then pervasive, significant, repetitive patterns of repetitive interests and behaviors seen in these individuals. Now, I really want to highlight that this is a developmental disorder. This is not something that you can, and when I say developmental disorder, I mean it's something that's present from early in life. This is not something that people develop in their 20s or 30s or 40s. This is a disorder with a childhood onset. And we'll talk a little bit more about that as we go. But anytime somebody comes into your office as a clinician or a diagnostician, presenting with maybe difficulties with social interactions and so forth, and they've onset recently, we're not talking about an autism spectrum disorder. by its nature, it is something that has an onset in childhood. I should say as well, as with many of the disorders that we talked about this year, even though there's a core set of criteria or a core set of symptoms that everybody must, with this disorder, shares by virtue of having this disorder, the severity and presentation of these symptoms vary very widely. If you've met one person with autism spectrum disorder, you've met one person with autism spectrum disorder, if that makes sense. It's very hard to lump this very broad category of people into this is what they look like, or this is how they behave, or however we want to categorize this. There's a lot of heterogeneity in the way that they present, or in the way that people with autism spectrum disorder present. And hopefully that will be clear by the end of the lecture today. So historically speaking, the term autism was coined, or autism in the way that we think about it, I should say, was originally coined by Eugene Bleuler. I'm not Swiss or German, so I'm not very good with these names, but we'll call him Dr. B or Mr. B. I don't know if he had his doctorate. Was a Swiss psychiatrist who contributed to early studies of severe mental disorders or mental illnesses. And he referred to, when he was talking about autism, he was referring to a severe symptom of schizophrenia, in which individuals lost contact with reality. So at that time in 1911, as far as Eugene B. here was concerned, autism was not a disorder in its own right. It was rather a symptom of schizophrenia, and specifically it described a cluster of symptoms in which individuals lose contact with reality, so to speak. It should also be noted, I think it's always important to make mention of these things. This gentleman is widely considered to be one of the important figures in the history of psychopathology, and I won't take that away from him. He did make some pretty important contributions, but he was also, like many people, or many noted social scientists at the turn of the 20th century, was a very outspoken eugenicist, and he advocated for forced sterilization of individuals living with mental disorders, including individuals living with schizophrenia and what we would now consider autism. So certainly a complicated legacy on that side of things, and I think it's important to remember that even though he made some important contributions to this field of work, he also did some pretty horribly he advocated for some pretty horrible and unethical treatment of individuals and groups of people. Now, going into the 1940s, Kanner and Asperger described children, they independently described groups of children in a series of studies who were exhibiting relatively unusual behaviors. Now, since then, these children have been recognized as having what we would now recognize as autism spectrum disorder-like impairments, namely in that they were socially disengaged, they demonstrated very little eye contact, and they generally had very poor language abilities. Now, I kind of alluded to this in the previous slide, but these are some of the core symptoms or characteristics that you'll see in people with autism spectrum disorder. It should be noted as well that Asperger, his sample that he was describing had notably less impairments than the other sample here by Kanner. And for that reason, or perhaps unsurprisingly, future generations, when they were talking about Asperger's disorder, going into the DSM-4, typically described individuals with less severe versions or less severe presentations of autism spectrum disorder. Okay. Moving on from the 40s, going into DSM-3, autistic disorder and childhood pervasive developmental disorder were the only two pervasive developmental disorders that were described. So you had autism or a less specific pervasive developmental disorder that also had an onset early in life, essentially from birth, if not shortly after. Moving into DSM-4 in the 80s, we started to see, or not started to see, they created a number of newer diagnoses to capture different aspects of presentations, similar to what we would have seen with autistic disorder or pervasive developmental disorder in DSM-3. These include Asperger's, something that I think is relatively well known in the general public. And in general, the disorders that were described in DSM-4, I think there are 4 different types or 5 different types of what we now consider autism spectrum disorder. They were all added to DSM-4. Largely, these new diagnoses captured more mild versions of what we would now consider to be part of the autism spectrum disorders. Moving into DSM-5 in the last 5 or 6 years, over the last 10 years at least, they largely reduced this set of 4 or 5 different disorders describing autism into one category or one diagnosis called ASD, or autism spectrum disorders. Now, this reduction in subtypes was relatively controversial at the time, I would say. Not just me, I think it's generally agreed upon that it was controversial at the time. Autism diagnoses have become a sense of identity for large groups of people. I think a perfect example is individuals or individuals who have loved ones who are living with a diagnosis of Asperger's syndrome. When DSM-5 came along, now they technically no longer had Asperger's syndrome, and that's not because of any changes in their symptomatology. Rather, the diagnostic criteria were changed, and the diagnosis of Asperger's was no longer used in the DSM. That, of course, created difficulties, or there was a perception that it was going to create difficulties for individuals who were receiving insurance coverage, let's say, who had an Asperger's syndrome diagnosis. Now they didn't have that diagnosis. That said, for the most part, there was a clause put in DSM-5 that somebody with a well-established history and well-established diagnosis of something like Asperger's disorder or Asperger's syndrome would still meet criteria for DSM-5 autism spectrum disorder. So it wasn't, the hope was that not a lot of people were going to be lost in the system. As far as I'm aware, that is the case, that not too many people were lost in the system or were no longer met criteria for a DSM diagnosis moving into DSM-5. Now, it should be noted that this reduction in autism subtypes was not done arbitrarily. This was a scientifically informed decision, and it was done largely because there was very poor reliability in the ability of clinicians and diagnosticians to distinguish subtypes of autism that were categorized in DSM-4. For this reason, you would have the type of autism that somebody was diagnosed with tended to be more linked with where they received the diagnosis, i.e. which clinic they received the diagnosis from or what doctor they received the diagnosis from, than their actual presented behavior. Because of this and other reasons, including there were a lot of common changes for individuals to change their the diagnosis that they met criteria for over time. There were shifts in behavior are common in autism, and because of that, people would shift in and out of different diagnostic criteria. It was recognized that these different subtypes of autism recognized in DSM-4 were not very useful. In fact, they were pretty confusing, actually, and so they were removed and moved into a single category of autism spectrum disorder in DSM-5. Now, in terms of the diagnostics for or diagnostic criteria in DSM-5, there are 2 large or broad categories of symptoms or behavioral manifestations that we're going to be seeing with an autism spectrum disorder diagnosis. I'm going to try to just keep saying autism from now on instead of autism spectrum disorder or autism spectrum diagnosis moving forward, so bear with me with that. The first one is persistent deficits in social communication and, whoa, that's a typo. What am I trying to say here? Quick second here. I'll have to edit this out. remember. If I didn't remember, then that means that you're watching me right now and laughing at me or rolling your eyes at me, so I do apologize for that. Social interaction. So persistent deficits in social communication and social interaction, that should say social interaction, across multiple contexts as manifested by all of the following currently or by history. So it could be happening currently that you're experiencing some of these symptoms, or historically that somebody is experiencing these symptoms. And it should be noted that the DSM specifies that this is not an exhaustive list of potential manifestations of deficits in social communication or social interaction. These are just some good examples. So these include deficits in social emotional reciprocity, so abnormal or unusual social approach behaviors, failure to have or engage in normal conversation patterns with others, and lack of initiation of interactions with others, social interactions, so not actually initiating conversations with other individuals. A second symptom, possibly falling under category A here, is deficits in nonverbal communication. So poorly integrated verbal and nonverbal communication. So the verbal communication that they're engaging in, if they are engaging in verbal communication, not necessarily matching nonverbal communication strategies. For instance, maybe poor eye contact, or really flat facial affect while they're talking about something that's they're saying was very exciting or very enthusiastic. They found it to be very exciting and pleasurable, but not really giving a lot in terms of the nonverbal cues that one would expect from somebody that's experiencing a lot of pleasure or happiness from some activity or behavior. Abnormal eye contact is kind of a classic symptom that we often look for in autism, and that includes either not making eye contact, avoiding eye contact or gaze, or very inconsistent or poor eye contact. Deficits in or lack of understanding of facial expressions or gestures. So these individuals might be experiencing a hard time really reading other people's emotions on their faces, or the nonverbal gestures that they make either with their hands, like I'm doing right now, or like kind of a good example would be kind of like eyebrows going up like this, like if you're like, not being able to understand what that means is what we're talking about here. And then deficits in developing and maintaining relationships. Now there's a couple of different examples here, but generally having difficulty developing deep, meaningful relationships with other people. As a child or a young child, that might look like difficulty sharing an imaginative play with other children, or showing a general lack of interest in engaging in relationships with other people, or difficulty adjusting behavior to be appropriate to the social context. But generally what we're talking about for criteria A is deficits in social communication and social interaction. That's what we're talking about here. The second criteria that we're seeing are restricted and repetitive patterns of behavior, interests, or activities manifested by at least two of the following. And again, these are not exhaustive examples, but these are the more common ones that we're going to be seeing. So stereotyped or repetitive speech, motor movements, or use of objects. So this would be like a stereotyped motor movement would be something like hand fluttering. You see people do this, or like rocking, things like that. In terms of repetitive speech, you might have people repeating the same phrase over and over and over again, even outside of a context when that statement or that phrase that they're repeating would be appropriate. And then repetitive use of objects, I think a good example of that would be like stacking, or making sure things are aligned in a certain way is a pretty common thing that you would see in children with autism. Excessive adherence to routines, ritualized patterns of verbal or nonverbal behavior. This would be really having a hard time shifting out of a normal routine, or engaging in activities that are outside one's normal routines of behaviors. Highly restricted, fixated interests that are abnormal in intensity or focus. So being very, very engaged in one aspect of, I don't know a good example of, let's say, what's a good example? Maybe a child is very excited about Harry Potter, and somebody with, like, many children are excited about Harry Potter, but somebody with autism might be super focused on learning all of the spells that are cast in Harry Potter, and to the point where they struggle to engage in any other areas of interest, or explore any other areas of interest that might be available to them, and they'll just repeatedly focus on the spells in Harry Potter. That's just an example. In terms of, what's the show that my wife was watching recently, and it was a pretty good depiction of autism. I think it's called Atypical. It's on Netflix. And the young man in that show has a high degree of fixated interest on penguins. And constantly talking about penguins, knows a lot about penguins, and it's hard to shift him off of talking about penguins when he's focusing on it. Hyper or hypo reactivity. So hyper being an overreaction, and hypo being an underreaction to sensory inputs. This could be things you often hear about people with autism having hypersensitivity or hyperreactivity to certain textures, like clothes, certain fabrics, maybe certain sounds will really upset people. But we're also talking about hyporeactivity, maybe just ignoring sounds that are in the environment that most other people would pay attention to, or visual stimuli, things like that, being able to just tune those out completely as if they're not there. So it could either be too much hyperreactivity or hyporeactivity, not responding at all, or really responding infrequently. So these are the kinds of things that we're talking about. Like I said, persistent deficits in social communication and social interaction, as well as restricted repetitive patterns of behaviors, interests, or activities. In addition, these symptoms are present from an early developmental period. They may not be fully manifest until later on in life, especially going into like adolescence or maybe late childhood, when social demands go up. People kind of expect more of people as they get older in terms of social contexts. And it may be that these symptoms don't become problematic for the individual or for their family or friends until later in life, or later in childhood, when more is expected of them and they're not able to keep up with those demands due to these criteria A and criteria B symptoms. That said, they are always in autism present or notable from an early age, typically before the age of 2. And again, like other disorders, symptoms cause clinically significant impairment in different areas, and these disturbances are not better explained by other disorders like an intellectual disability, a global developmental delay. Now that said, intellectual disabilities and autism spectrum disorder do frequently go together, but again, it says it here, to make a comorbid diagnosis of autism and intellectual disability, social communication should be below what's expected for that person's general developmental level and their intellectual abilities. Now, within autism spectrum disorder in the DSM-5, there's various specifiers as well. These are kind of criteria to kind of give subcategories, I guess you could call them that. They're called specifiers in the DSM that speak to whether the individual also has accompanying, whether they have intellectual impairment. So we're talking about like an intellectual disability, whether they have language impairment. So either difficulty with verbal language or nonverbal language, like sign, or from anywhere from difficulty with it to a complete absence of language ability, as well as whether, another specifier is whether it's associated with a known genetic or medical condition. This is one of the few DSM disorders, it may be the only DSM disorder that I'm aware of, at the very least, that has known genetic contributors and known genetic conditions for which autism is a frequent outcome. and this includes Rett syndrome as well as tuberous sclerosis complex, TSC. Now, it doesn't necessarily mean, at least for the case of TSC, that if you have TSC, tuberous sclerosis complex, that you're going to also have autism spectrum. It's just that this is a known disorder that can lead to autism. That said, most of the time we don't have a clear explanation of why somebody has developed autism, and we'll get into that in a little while. In terms of associative features that we see with autism outside of the actual diagnostic criteria, some of them are related to the diagnostic criteria. So we were talking earlier about deficits in social interactions, impaired social imitation. This would be deficits or difficulties in imitating other behaviors that somebody's seeing somebody else do. So maybe social learning, so to speak. Poor joint attention. So that would be like orienting somebody to another feature in the room by pointing or saying, hey, come look at this with me, and following somebody's gaze. Most normally developing children are going to be able to do that without any real problems. Somebody with autism is going to struggle with maintaining or engaging in this joint attention processes. Poor orienting to social stimuli. So this is going to be like somebody coming in the room and saying, hey, how are you doing? How's your day? Or even just walking up to somebody and trying to get their attention. Most, again, typically developing children are going to attend to that person. Whether they're going to be frightened or not is another story altogether, but they're going to be aware that somebody's walked in the room, they said hello, and they know that they should at least attend to that person and probably engage with them. Somebody with autism, depending on the severity, of course, is going to struggle with orienting to these social stimuli or to somebody calling their name, for instance, things like that. Poor face perception, we'll get into that in a second, and it kind of ties into deficits in emotion perception, recognition, and expression. One of the classic tasks here that's been used is this kind of same or different task, where individuals both with autism and those that are typically developing children will be shown different types of stimuli. And what we see is when we're looking at facial stimuli, people with autism tend to have deficits in their ability to distinguish whether these are the same face or different faces. Same thing goes for distinguishing different types of emotional cues on faces, whether these are the same types of emotions or different. People with that are typically developing generally don't have any problem seeing these two faces and saying these are different faces. Somebody with autism is going to perform generally lower and have a harder time distinguishing whether these are different or the same face. Now, contrast this with non-facial stimuli, like these these glasses here. People with autism are going to be able to distinguish that these are not the same, they're subtly different or slightly different glasses, just as much as somebody that is typically developing. So it seems to be very specific to facial cues and emotional cues, things that are important for social processing and social interactions. And that kind of goes along with those core features of autism that we were talking about earlier in terms of social deficits and deficits of social communication and social interactions. Another feature that we see brought up a lot, and I mentioned it earlier, it was kind of a core symptom or a classic symptom that you see in autism is poor eye contact or inappropriate eye contact. When we look at eye tracking paradigms, so this is where we have a machine that essentially is able to track, we've got one in the lab, it's pretty cool, where somebody is actually, their pupils are actually looking at on a screen. When we show people with autism a face like this, or even a full face, children with autism generally spend a lot less time looking at the eyes, whereas people that are typically developing, don't have autism, tend to spend a lot of time looking at the eyes of individuals. People with autism they still will periodically look at the eyes, but they spend a lot more time looking at the mouth, looking at the ears, looking at features that are not the eyes. And this is true of not just children with autism, but also their siblings who do not have the disorder themselves also tend to spend less time looking at a person's eyes than healthy controls or so-called typically developing children. I should mention that this is like, it seems like a minor thing, not looking at somebody's eyes, but this is a pretty prominent factor in normal social discourse, is that you do engage in some eye contact. Now, of course, that's culturally bound and it changes from culture to culture, but there is some level of what is considered normal or appropriate eye contact within different cultures, and people with autism generally aren't able to engage in that normal or acceptable level of eye contact. So sorry about that. We kind of had an error there. When we're talking about pragmatic language, we're talking about social language skills that we use in just our interactions with other people. And this could include eye contact. It could include turn taking within a conversation, use of humor, tone of voice. The tone of my voice can change the meaning of what I'm saying. If I say something like, somebody asks me how I'm doing, I'm like, oh yeah, I'm doing great. It's been a good week. Versus if I say, oh yeah, I'm great. Everything's fantastic. People without autism and people that are able to engage in or understand pragmatic language are going to have an understanding that this is the second case. I'm not actually great. I'm being sarcastic. Somebody with autism is likely going to struggle with that distinction. Perseveration, so an echolalia, we're talking about repeating things over and over again, maybe repeating what other people are saying and just echoing them a lot. Inappropriate shifting of topics, so it might be you're in the middle of a conversation and somebody with autism might just cut you off and say, okay, well, we're going to go do this now. Or they might not even say we're going to go do this now. It's just the end of the conversation is right there. It's very abrupt, and it's an inappropriate shift, socially speaking. And impairments in perspective taking, I want to talk about that in a little bit when we're talking about theory of mind, but this is going to be difficulties taking the perspective of another person and understanding where they're coming from. Additional features that are associated with autism include executive functioning impairment. So this is talking about attention, planning out behaviors, things like that. Concentrating. This is not necessarily specific to autism. We see executive dysfunction in a lot of different mental disorders, including depression, anxiety. Pretty much every disorder I can think of involves some level of executive dysfunction, but it is important to note that it's also present in autism. Abnormal attention, we kind of already talked about this. I do want to mention here, like in terms of poor generalization, we're talking about learning a new behavior and struggling to generalize it to other contexts. So somebody might learn how to use a cup to drink. And if I give them a different cup or a cup that looks very different than this, they might still know how to use that to drink. But if you have difficulties in generalizing this concept to other areas, now this is a very basic example. That might be too basic for somebody with autism in terms of having a deficit there. But it might be if I give them a different cup that looks different, they struggle to figure out how to use it properly or engage in appropriate behavior with that. Let's go on to prevalence. Oops, I meant to put this somewhere else. I'll come back to this. And we're back. In terms of prevalence, we're talking about things like, sorry, it was historically thought to be relatively rare. This is going back into the early 20th century. It was thought to be about 1 in 2,500 children, which is a relatively rare disorder. Recent estimates suggest that it's closer to 1% of the population. You'll see different numbers, including things like 2%, 4%, things like that. But generally, as far as the best epidemiological research that I've seen, puts it closer to around 1%, a little bit under 1% often. Now, over the last 20 to 30 years, there's been a very large increase in terms of rates or prevalence of autism spectrum disorder. Now, there are some people that will state that this is because of something to do with increase in allergies or allergens in the environment, increased exposure to vaccines or mercury, either in vaccines or not. There's other things that people talk about as being proposed as to being the source of this increased prevalence. That said, the best research that we have, and we'll talk about that a little bit more going forward, support the idea that it's likely more due to better recognition of autism and broadening the scope of diagnosis, so making it so that more people are eligible for a diagnosis of autism based on the diagnostic criteria. And for these reasons, that's why we're seeing an increase. It's likely more to do with better recognition than broadening the scope of the diagnosis, but both play a part. And there's no evidence that it has anything to do with allergies, vaccines, mercury, or anything in terms of actual changes in the frequency with which this behavior occurs. It's just that we're recognizing this behavior as being part of autism now more frequently. And again, I want to speak to that here. Like I said, much of the increase in terms of the prevalence of diagnosis has come from less severe forms of autism being recognized, things that would have maybe 20 years ago been called like Asperger's and things like that, or more high functioning forms of autism are now being recognized as falling under this, this umbrella of autism spectrum, or the autism spectrum. And for that reason, rates have gone up. Diagnostic criteria have become less strict, so it's increased the likelihood that if you are exhibiting some unusual behavior that is, or abnormal behavior, I should say, that is consistent with autism, it's less strict on how much you have to have now, and for that reason, rates have probably gone up. Increased practice of diagnosing autism spectrum as being comorbid with medical conditions, whereas before you couldn't have comorbid medical conditions, certain medical conditions that were classified as also having autism. So things like Rett syndrome, I mentioned earlier, is now recognized that if you have Rett syndrome, you can also have autism. It's not mutually exclusive. There's much greater efforts at screening for autism. This is something that I worked in an autism screening clinic for a couple of months, and I think I met one child, even though I was involved in the assessment of about 10 or 15 of them, that actually had autism, and that's because there is much better efforts at screening for autism now. And that's also partly due to massive increase in public awareness. There's been huge anti-stigma campaigns and just huge campaigns in terms of lobbying for increased access to care, treatment, interventions, and things like that, and increased access to educational opportunities and occupational opportunities for people with autism. Now, this has come along with generally a decrease in stigma. The stigma is still there, but it also has come along with greater efforts at screening and recognition that autism does exist, and it can come in more milder forms. For that reason, the best evidence is suggesting these are the reasons that we're seeing increases in the rates of autism over time. In terms of socioeconomic status, there seems to be no relation to the prevalence of autism spectrum and socioeconomic status or cultural differences. So people that are exceedingly wealthy and people that are living in extreme poverty are no more or less likely to have autism spectrum, or have autism, sorry. And same thing, that it doesn't seem to be that there's cultural differences in that if you go to certain countries or certain parts of the world or certain cultures, that there seems to be more or less prevalence in autism spectrum disorder. It seems to be pretty universal in that case. However, with regards to sex differences, we see that males consistently have a 3 to 4 times higher prevalence. There's 3 to 4 times more males with autism spectrum disorder than females. However, females who do have a diagnosis of autism tend to be more likely to also have severely low cognitive abilities or intellectual disabilities. And it tends to be more severe forms of autism that you see in females. That said, males still far outweigh in terms of the rates of autism than females. Let's talk about course real briefly here. Most individuals exhibit symptoms prior to 12 months of age. That said, diagnosis typically isn't made until age 2 to 4. It does happen after that as well, but now with increased awareness, like I was mentioning before, many people are diagnosed sometime between ages 2 and 4. That's not to say that the symptoms don't begin before then. Again, like I said, most people do exhibit some symptoms before that. And oftentimes, in retrospective recall, when you ask families, typically parents, about their child's behavior before diagnosis, they'll recognize that those symptoms were evident from very early on, prior to 12 months of age. Now, there are different developmental pathways within autism spectrum disorder. About 25%, so a quarter of individuals who are diagnosed with autism exhibit a normal developmental period, or normal developmental progress over their first year, and then experience a so-called regression. They begin to lose previously acquired abilities. So maybe up to the age of 1, they were maintaining good eye contact with their mothers, and they were laughing and giggling and stuff like that. They may have acquired some basic language skills like mama, dada, things like that, but then begin to lose those abilities over time. About a quarter of kids with autism exhibit that pattern. But the majority don't experience that regression. That will show deficits prior to the onset of diagnosis. In terms of the types of symptoms that we're seeing in younger children, younger folks, just younger kids, it's more typical or more prominent to see the repetitive motor movements in autism. So these are the things like the hand flapping that I was talking about, the repetitive rocking, just repetitive movements. Whereas restricted interests, as I was talking about before, tend to be more prevalent among older people with autism or older children with autism. So you do see a change in what symptoms are more obvious or apparent over developmental course. Okay. Symptoms do typically improve over time. However, this does not mean people recover from autism. This is a pervasive developmental disorder, and for that reason, it's a lifetime disorder. That said, you do see, especially with early intervention, people's social skills can improve, and they do improve. People's interests tend to broaden, things like that. They're able to engage in more socially normative or appropriate behaviors, but they do tend to continue to have deficits in these areas. Importantly, early intervention is essential, and this is increasingly recognized. Up to 70% of those without treatment early on demonstrate very limited progress in terms of improving social interactions, social skills, things like that. And for that reason, they tend to have worse outcomes later down the road. So early recognition and intervention is essential. In terms of outcomes long-term, even though we do see improvements, the vast majority of people with autism do continue to rely on family and social services well into their adulthood. They generally struggle to develop or to maintain friendships or close relationships with others. And they generally struggle with occupational success or engagement. Now, this isn't to say that there aren't people with autism that do succeed in these different areas. It's just that typically most people do continue to struggle in these areas throughout their life. Now, that may be shifting as we're seeing increased recognition of autism and importantly, with increased recognition and better screening, we're also seeing earlier interventions and more intensive interventions being undergone. So it may be that 10 years from now, when we're talking about this, we're recognizing that with these better interventions and earlier interventions, people have better outcomes long term. But as it stands right now, the outcomes tend to be relatively poor going forward. In terms of predictors of good longitudinal outcomes in terms of these features here, living independently, developing relationships or friendships, and succeeding in occupational areas, i.e. work or volunteerism and things like that, education. Having a normal range IQ is one of, if not the best predictor of positive longitudinal outcomes for people with autism. Early language attainment and retaining those early language skills is also very important predictor of longitudinal outcomes. And then higher scores on reciprocal social skills, so being able to engage in a back and forth interaction, social interaction early on is again a good predictor of more positive longitudinal outcomes among children with autism. Moving into comorbidity, perhaps the most common things that we're seeing are intellectual disabilities. When we're talking about an intellectual disability, we're talking about an IQ score below 70. Sometimes you have people that will still receive diagnosis for intellectual disability that have an IQ score slightly above 70, but very poor functioning in their day-to-day lives. Generally speaking, we're talking about an IQ below 70, and approximately 40 to 70% of people with autism do have an intellectual disability comorbid with their autism diagnosis. Generally, what we see, even with that low IQ score, is, or among those with the low IQ score with autism, they tend to perform very poorly in verbal areas of cognitive assessment. Even relative to their low score, they're still performing under what you would expect even with that IQ score. And then relatively high performance in non-verbal areas of cognitive assessment. And this is consistent with the diagnostic criteria that we talked about earlier. I do want to say as well that a common trope that we see in media is this idea of savants or people that are exceedingly brilliant or exceedingly skillful or talented in different areas that have autism. Now, up to 25% of children with autism display a special cognitive ability, what some people will call like a splinter skill, that's above average for the general population and significantly higher than what you would expect given their cognitive ability. Generally, this skill or splinter skill will focus on one specific area, very specific within spelling or reading or math, music, drawing, things like that. It'll be one specific thing that they're very good at. And then it's typically related to their one of their restricted areas of interest. For instance, I was talking about Harry Potter spells right before. It might be that the child with a splinter skill in that will be able to recall all of the spells with relative ease, but will struggle with memory in other areas or struggle to recall other facts about Harry Potter, let's say. But with the spells, they're very, very talented at recalling those things. And about 5% of children, so that was 25% of children with autism display some sort of splinter skill. About 5% are sometimes referred to as savants, in that they display exceptional abilities in a specific area that far outstrips the abilities of the general population. There's a couple of examples in the textbook. One that stood out to me was of a young boy with autism spectrum disorder who had an IQ of 60, so a very low IQ cognitive ability, but he could recite daily lottery numbers, every daily lottery number for the last 5 years. That is an unusual cognitive ability that the vast majority of the population would not be able to engage in that kind of ability. But this young man was able to do that despite having a very low IQ. So that's about 5% of the population of people with autism. Epilepsy is another common comorbidity that we see. It's more common in females as well as those with intellectual disabilities, but we see that in anywhere between 10 to 39%, 10 to 40% of individuals with autism. Anxiety disorders, we see a wide range in estimates, but it's likely on the higher end that we see comorbidities with specific phobias, generalized anxiety disorder, and social phobias. This is perhaps unsurprising given if you're going out and having to engage in this world that's very social and you struggle or are unable to glean information from people's social cues or nonverbal cues or even verbal cues, that's going to cause a lot of anxiety. And along with that, you can develop anxiety disorders. Major depressive disorder, again, wide range of estimates, but it tends to be more common in higher functioning adults with autism spectrum disorder. And then we also see ADHD, predominantly the inattentive subtype, is present in about 20% of people with autism. Okay, moving on here. In terms of etiology, there's a couple of different theories or ideas about what's contributing to the development of autism. Deficits in theory of mind are one of the more prominent ones that we see talked about. Theory of mind, for those of you who aren't aware of, is this idea of an individual's ability to take the perspective of another person and understand that other people have their own thoughts, beliefs, intentions, and emotions that are distinct from one's own thoughts, beliefs, intentions, and emotions. So the fact that many of you out there are aware that I'm having my own thoughts right now, I'm looking at my computer and my webcam right now, and I'm having my own feelings about the day and that are distinct from yours, means that you have an intact theory of mind. Now, children with autism often demonstrate deficits in developing theory of mind. And it may be that they don't, not necessarily that they lack it completely, but that it's delayed relative to other children who are able to develop throughout childhood an intact theory of mind. Now, this deficit in theory of mind is relatively specific to autism spectrum disorder. We do see it in some other disorders like schizophrenia, but with regards to autism, this is a more classic description of or associated feature with autism. Now, I encourage you to read your textbook. There's some good examples of how we test for theory of mind that are pretty interesting. And if you're interested in that, I would encourage you to just even YouTube theory of mind test, something like that. And there's some good examples of how we test things like that. Now, this theory of mind deficit is also, it's important to note, is consistent with the deficits in social interactions. If I'm not aware that that person across the room is having their own thoughts that are different from mine or has their own individual experience, I'm going to struggle to interact with them and understand where they're coming from, especially when our beliefs or our thoughts, intentions, emotions, whatever, differ. It's going to be a real struggle for me to comprehend where they're coming from, and probably going to be frustrating for me as well. Now, early on in the 20th century, or in the first half of the 20th century, there was, largely coming out of psychodynamic theory, psychoanalysis, it was theorized that autism was caused by so-called refrigerator parents. And let's be honest, this was a very sexist time. When we talk about refrigerator parents, it was typically refrigerator mothers that we were talking about. And it was thought that mothers that were cold and rejecting of their children caused their child to develop autism. So this was extremely, extremely stigmatizing. You have a child that's developed autism or has autism, and who do the doctors blame? Mom. It's mom's fault for being cold and not being a good mother, essentially. This is patently false. There is no evidence at all that parenting has anything to do with the development of autism. Parents of children with autism don't differ in terms of parenting style, or marital satisfaction, or other family-based variables. It's unrelated to autism. I really want to emphasize that. That's not to say that parenting a child with autism is easy. In fact, there's a lot of struggles that can go along with that. However, there's no evidence to suggest that there's something about an individual style of parenting that contributes to the onset of autism, okay? So if anybody ever says that, you tell them they're wrong. Genetics play a very large part in terms of variability in autism, or the onset of autism. Development of autism is what I'm trying to say. If you have a sibling with autism spectrum disorder, there's a 15 to 20% chance that you're also going to have autism. Compare this with about 1%, a little bit less than 1% of the general population. This suggests that there's a large genetic component involved with this, especially knowing that what we just said, that parenting doesn't seem to have anything to do with the development of autism. and importantly, twin studies demonstrate that autism is approximately 50% heritable. So about 50% of the variance in autism diagnoses has to do with genetics and biology. Importantly, family history of autism is also associated with other behaviors that we consider as being kind of autism adjacent. So even amongst other family members that don't meet full criteria for autism, there is still evidence of impairment in social skills and language, poor theory of mind development, and more restricted interests. This is even in people that do not meet full criteria for autism. If you have a family member with autism, chances are that other family members are going to exhibit deficits in these areas, not to a clinical level, but some deficits. In terms of the prenatal and perinatal environment, we see higher rates of pregnancy and birth complications in autism among people with autism. This talks about people that might have near spontaneous abortions, so they almost the mother almost lost the baby, so to speak. Having to undergo induced labor, statistically shorter labor periods, fetal distress, and having to undergo emergency C-sections tend to be associated with autism. However, the research has shown, and the statistics have borne out, that this tends to be more relevant to risk for intellectual disability than autism per se. So it may be that we're capturing more of the intellectual disability, which is common in people with autism, than risk for autism in itself. There was also arguments historically that there was a season of birth effect. So basically when you were conceived, as well as when you were born, could contribute to risk for autism. The thought was that maybe individuals that were born in certain times of the year were more likely to be exposed to different seasonal viruses and things like that, either in the womb or shortly after birth. However, there's very little evidence to support this, and it's likely not a factor in terms of risk for developing autism. In terms of neuroanatomical factors, I won't go through all of these, but it's important to know that there are some relatively consistent differences that we see in the brains of people with autism versus those that don't have autism or are more typically developing people. A lot of these, the ones that are highlighted tend to be related to emotional functioning, as well as social functioning areas of the brain, or areas of the brain that are responsible for those things. All right, I'm moving through here. This one I want to spend a little bit of time talking about because for whatever reason, this is a theory that just won't die, and it needs to. There was, especially late 90s into the 2000s kind of thing, there were a number of people that were hypothesizing, and they published evidence supporting the idea that vaccines given in rapid succession can lead to the development of autism, as well as certain additives in vaccines, so maybe mercury or other things that are present in vaccines could lead to the development of autism. This is simply wrong. There's no evidence to support this at all. Those early studies that were published were largely focused on the measles, mumps, rubella vaccine. Other vaccine ingredients have been attributed to this as well. But largely these arose out of a series of papers in the late 90s by one Dr. Andrew Wakefield and his colleagues. One of the big studies there was published in the hugely influential medical journal, The Lancet, and stated that the authors found statistical evidence linking the measles, mumps, rubella vaccine with the development of autism in children. And this led to drastic decreases in the rates of vaccination across the globe to this day, with some regions losing herd immunity. We've heard of in the last couple of years, children coming down, or groups of children coming down with measles due to anti-vaccination movements related in part to this specific paper and Andrew Wakefield. In the decades following the paper, evidence emerged, not just evidence, proof emerged that Dr. Wakefield had not only grossly overstated his findings, he's found to have numerous conflicts of interest, including a patent on a competing vaccination. So a vaccination, he was saying that his competitor was basically causing vaccine or autism, but his vaccine would not. And eventually it emerged that he had in fact just altered all of the participants' data in his studies. He made everything up to make the relationship appear like it was real. He did other very strange things, including testing at his child's birthday party. Everything he did with these regards to these studies were largely unethical and not grounded in science at all. There's been arguments that breaking vaccinations into smaller doses reduced risk for developing autism. In fact, it does nothing of the sort, but it does increase the likelihood that you are going to develop some kind of disease or infection that could kill your child. So I could go on about this for days and days and days, but I really want to emphasize there is no scientific evidence. I would really want to underline that scientific evidence that immunizations have any part to play in developing autism. It's bullshit. So vaccinate your children, vaccinate yourself, and you don't have to worry about autism with regards to that. It doesn't play a role. I do also want to say that another piece of evidence for this that I put in here is large samples, very large samples, show that while the incidence of autism has been on the rise, as we've talked about before, rates of vaccination have remained constant. And if vaccinations were linked to this, we should be seeing increases in vaccination. If anything, rates of vaccinations have actually decreased over the last decade and a half due to this anti-vaxxer movement. But yeah. Okay, last slide that I really want to talk about here really briefly is treating autism. The therapeutic intervention of choice, the one with the most evidence supporting it as far as I'm aware of, is applied behavioral analysis, as well as, which is sometimes called ABA, as well as other behavior modification techniques. We've talked about these earlier in the lecture series, earlier in the course, but generally, these behavior modification techniques and ABA focuses on improving communication skills, including very basic social skills like maintaining eye contact, having reciprocal interactions, things like that, as well as reducing self-injurious behaviors, which can sometimes be problematic for children with autism, especially with repetitive behaviors like head banging. You can get to the point where some kids will be banging their head against the wall or the ground to the point where they'll injure themselves. So behavior modification techniques aimed at reducing those are very important as well. Intervention is typically early and intensive. The earlier, the better. And modern approaches try to get intervention started as soon as a diagnosis is reached, if not shortly there before. And it can go up to 24 hours per week of one-on-one intensive therapy between an ABA therapist as well as their client or their patient. So extremely intensive therapy, extremely expensive therapy, but it does, as far as the research is showing, it does pay in dividends, so to speak, in terms of positive outcomes that we see among children that are undergoing this type of therapy. There is some evidence that medications may help with alleviating some of the associated symptoms of hyperactivity, anxiety, depression, but generally effectiveness, as we've talked about before with those disorders, is relatively limited, and there's not a lot of evidence to support their use. So ABA, behaviorally oriented methods for intervention are the go-to. All right, I think that's it. I hammered through that. I want to thank everybody. This is not the ideal way to end the course this year. As I mentioned to many of you, this is my first time teaching. So really thank you for a great semester, and I want to wish you all the best of luck going forward. If you ever have any questions about the course material, please send me an email. We can set up a session to meet online or in person if the quarantine stuff ends. And then also going forward, if you have any questions about grad school, pursuing a career in clinical psychology or clinical sciences, please don't hesitate to reach out to me. I'm happy to talk about those things. And thank you very much for your time. I wish you guys the best of luck. Thanks.